Hello friends, I'm Dr. Ram. Today I will discuss the treatment of hemorrhagic stroke. Aims of treatment: save the person's life, relieve symptoms, repair the cause of bleeding, prevent complications, start rehabilitation therapy as soon as possible. General measures: admit to ICU. Stroke is a medical emergency. Time lost is brain lost, so immediate treatment need to be started. Brain CT or MRI to demonstrate the site of lesion. Distinguish between ischemic stroke, shows hypodense areas, and hemorrhagic stroke to identify the conditions that mimic the stroke, that is, cerebral tumor or abscess. Imaging is performed immediately in the following circumstances. A brain magnetic resonance imaging scan can be done later to better understand what caused the bleeding. Blood tests, ECG, conventional angiography may be done in some cases to identify aneurysms or an arteriovenous malformation, although CT and MRI are more often used. Nasogastric tubing by an experienced hands. As in stroke, it is not easy to pass NG tube. Maintenance of hydration, frequent turning of patient to avoid bed sores. Prevention of DVT by TED stockings. Patient lying at 30 degrees head raised. Catheterize the patient if there is urinary retention. The patient will need to rest in bed and avoid activities that may increase the pressure in the head. Increased intracranial pressure such as bending, lying flat, sudden position changes, straining during bowel movement. The treatment of a hemorrhagic stroke depends upon the cause of bleeding, high blood pressure, use of anticoagulant medications, head trauma, blood vessel malformation. Most patients are monitored closely in an intensive care unit during and after a hemorrhagic stroke. The initial care of a person with hemorrhagic stroke includes several components: determining the cause of the bleeding, controlling the blood pressure, target BP of stopping any medication that could increase bleeding, warfarin, aspirin. If the patient has been taking warfarin, specific treatments such as factor 7A or transfusions of blood clotting factors may be given to stop ongoing bleeding, mirroring and controlling the pressure within the brain. Pressure within the brain can be measured by placing a device known as ventriculostomy tube through the skull into an area of the brain called the ventricle. If the pressure is elevated, a small amount of cerebrospinal fluid can be removed from the ventricle. A ventriculostomy can also be used to drain blood that has collected in the brain as a result of the stroke. The procedure can be done at the patient bedside or in an operating room. Pharmacological treatment of hemorrhagic stroke: anticonvulsants to prevent seizure recurrence, benzodiazepines, injection diazepam IV, 10 to 20 mg at a rate of 5 mg per minute. Repeat in 20 to 30 minutes if necessary while monitoring respiration. Control of blood pressure. Suggested agents for use in the acute setting are beta blockers: labetalol 20 mg IV over 2 minutes initially, then 40 to 80 mg IV over 10 minutes. Total dose not to exceed 300 mg. Angiotensin converting enzyme inhibitors: injection enalapril 1.25 mg per dose IV over 5 minutes, 6 hourly. Doses up to 5 mg per dose IV 6 hourly have been administered till safe blood pressure is achieved. For more refractory hypertension, agents such as calcium channel blockers: injection nicardipine IV 5 mg per hour by slow infusion, 50 ml per hour initially, may be increased by 2.5 mg per hour every 15 minutes, not to exceed 15 mg per hour. Or injection hydralazine 5 mg per hour by slow infusion, 50 ml per hour initially, may be increased by 2.5 mg per hour every 15 minutes, not exceed 15 mg per hour till target blood pressure is achieved. Avoid nitroprusside because it may raise intracranial pressure. Control of intracranial pressure, injection mannitol 1.5 to 2 grams per kg, IV infused over 30 to 60 minutes. For hemostasis, injection factor 8A 35 to 120 microgram per kg to hourly until hemostasis. For treatment of anticoagulation associated intracranial pressure, patients on warfarin have an increased incidence of hemorrhagic stroke. The need to reverse warfarin anticoagulation is a true medical emergency, and reversal must be accomplished as quickly as possible to prevent further hematoma expansion. Options for reversal therapy include the following. Because vitamin K requires more than 6 hours to normalize the INR, it should be administered with either FFP or PCC. Injection vitamin K 5 to 10 mg IV, diluted in 50 ml IV fluids and infused over 20 minutes. Plus injection fresh frozen plasma 10 to 20 ml per kg of body weight, or injection prothrombin complex concentrate. Dose based on pre-treatment INR obtained close to time of dosing. Infuse IV at a rate of 0.12 ml per kg per minute, equal to 3 units per kg per minute, up to a maximum rate of 8.4 ml per minute, equal to 210 units per minute. For lowering blood lipid levels, statins are used. Tablet simvastatin 20 to 40 mg daily with a goal to achieve low LDL. Prevention of stroke, control of hypertension. A combination of thiazides, diuretics and ACE inhibitors are used. Tablet enalapril 10 mg plus hydrochlorothiazide 25 mg, 1 to 2 tablets in the morning. Lifestyle modifications, exercise, diet control, less fat intake, cessation of smoking, weight loss.